Good afternoon, everyone. So today I'm going to talk about one of the very important lecture in obstetrics, that is management of normal labor. As a doctor or as a medical student, we all should know how to manage a normal labor. Now, in the last class, if you remember, we talked about definition of labor. What do you mean by normal labor? What do you mean by abnormal labor? What is delivery? What are the different stages and phases of the labor? Isn't it? We talked about that. Then we also talked about the mechanics of labor, how the baby descend down, what is flexion, what is extension, what is restitution, what is crowning, all of those things we talked in the last class. And this class, many of those things will be repeated again. And along with that, we talk about how to manage each of the stages of the labor. So let's proceed further. Now see here, this slide is telling us about the stage 1 and stage 2, stage 3 of labor. And in stage 1, please mute yourself, guys. Yeah, in stage 1, okay, uh, there is latent phase and active phase. Latent phase is the early phase and active phase is the late phase of stage 1. Latent phase means the cervix, okay, the cervix will start to efface and dilate, and it takes a long time to reach to 3 to 4 centimeter of cervical dilation. That is called latent phase. After latent phase reach, then there will be faster dilatation and effacement of the cervix, and that is known as active phase. You can clearly see in this picture. Look at the cervix is not properly effaced here, and here the cervix is very nicely effaced. In stage 2, the baby descends downwards, and stage 3 is the stage where placenta and membranes are delivered. Now let us talk about how to manage the case during admission. If a lady comes to the hospital for the purpose of delivery, how to manage her? See there, the first thing is to take the history. Complete obstetric history is taken. Present pregnancy as well as past pregnancy, the detailed history should be there. Then only obstetric history would be complete. What is the gravida? What is the parity? Is there any abortion in the past or not? How many living issues are here? So all these questions we have to ask. Detailed history of the present pregnancy will be taken, and history of the present labor would be taken, like from when labor pain started, how many hours before, and are they true labor pain or false labor pain. In the last class, we talked about the difference between true labor pain and false labor pain. Now, let me quickly revise because you people have not repeated probably. Now, true labor pain is a true uterine contraction. It progressively increases than before. Okay, and false labor pain doesn't follow this typical order. Okay, it doesn't follow. False labor pain probably occurs because of some infection or some ligament strain or something like that. But true labor pain occurs because of uterine contraction. This is a very important point. Labor starts only after true labor pain occurs. What is the frequency of the uterine contraction? What is the duration of uterine contraction, and how strong are they? Okay, this is an important question to be asked. Ask about vaginal bleeding or show. Now, show is not exactly speaking vaginal bleeding. This is that plug of mucus which was blocking the cervical canal. It just, release from there, and along with that, some amount of blood would become outside of vagina. That is called show. Rupture of membrane. Now, asks about whether there is a gush of fluid or liquid from the vagina or not. This gush of fluid or liquid occurs because of rupture of membrane, that is amniotic fluid. And you can ask about the color as well. The normal color is watery color or normal color. Asks about the fetal movement, whether she is feeling that or not. If there is no fetal movement felt by the lady, what does that mean? Yes, what does that mean?
Dead.
Dead
Fetal
fetus.
defects or fetal is dead.
Exactly. The most common cause is dead fetus. Okay, the fetus is already dead, and that's why she is not getting the fetal movement. So very correct answer. Another question asks about the medical issues which the lady probably was having. If nothing, it's very nice. Now, any medical issues like hypertension, diabetes, heart disease, kidney disease, liver disease, anything, you have to note that. Asks about was she taking any painkiller or not. Taking painkiller is not advisable during pregnancy. If anything is needed, we can admit in the hospital and give under our supervision. And is there what type of support from family she is getting? It's a very important question. Okay, so every lady who comes for the delivery in the hospital must be well supported by the family member, especially husband and other family member. So these are the important question to be asked. Okay, this is just the beginning. Now let's proceed further. Now, see here. What are the general examination and what are the urinary tests you like to do when the lady is admitted in the hospital for delivery? Have a look there. All the vital signs, and from head to toe, a quick general examination has to be done. Students already know what are those. Regarding the vital signs, pulse, blood pressure, respiratory rate, temperature, and pulse oximetry. But probably pulse oximetry is not necessary here because this we are talking about the normal labor and she is not in dyspnea. So pulse oximetry is not required here. Apart from that, all other vital signs would be recorded and noted down. Urine routine test is done. Glucose, ketone body, protein, presence of blood in the urine, or any nitrate or not. Now, a bit of explanation regarding this. Glucose is present in the urine in which case? Yes,
Diabetes mellitus.
very good, good. It's diabetes mellitus, you're right, but not always. Sometimes impaired glucose tolerance can also lead to glycosuria, that is presence of glucose in the urine. Some of the people, they have decreased renal threshold for the glucose. The decreased renal threshold, that is around 180 milligram. So after having a good meal, I may have blood sugar which reaches over 180, right? So during that time also some glycosuria may occur, but the most common answer is diabetes. Absolutely. Ketones. Now, the type of ketone, the type of ketone which is present in the urine is which ketone comes out in the urine?
Acetone?
No, acetone is a gas. Okay, so it doesn't come in the urine. Anybody else?
Beta hydroxybutyrate.
Beta hydroxybutyrate.
Okay, beta hydroxybutyrate. So see there. So listen it very carefully. Okay, this is an important question. Though we are talking obstetrics now, but this type of questions are commonly asked with medical student. There are three ketone body: beta hydroxybutyrate, acetoacetate, and acetone. Beta hydroxybutyrate is the form which is present mainly in the blood. Acetone comes out from the breath, that is through the lung, and acetoacetate form is mainly excreted in the urine. So this is the correct answer you should give. Protein. Now one question. In which case ketone bodies are formed? Okay, we have not talked about that. In which case ketone bodies are formed? What is that situation?
So the
Diabetes mellitus.
diabetic ketoacidosis.
Good. Diabetic ketoacidosis. Excellent. That is the most common one. Another is starvation ketoacidosis. Starvation ketoacidosis. If somebody is starved for a long time, then also ketone bodies will be synthesized. Proteins. Okay. So many causes where protein is excreted in the urine. Nephrotic syndrome, so many kidney diseases, blood, okay, glomerulonephritis, and nitrate. This is present in urinary tract infection. Okay, this is known as nitrite reduction test. So all these important points are there in the urine test. Now, second part of examination when the lady is admitted is abdominal exam. So we inspect the abdomen. Okay, inspection, palpation, percussion, and auscultation. These are the 4 steps for the abdominal examination. But in the pregnant lady, we modify a little bit regarding our examination. So inspection is done first. Second is a palpation. And during palpation, what is the lie of the fetus? What is the presentation of the fetus? What is the position? What is the station? And what is the attitude? So all these are important point we must find out in the baby. Now see there, lie. This is a longitudinal lie or transverse lie. Usually the lie is longitudinal. Whether it is a breech presentation or cephalic presentation, the lie is longitudinal. That is normal. Presentation. Which part, okay, is entering into the pelvic cavity first? That is the presenting part. So the most common one is again cephalic presentation or head presentation. Position of the baby. In the last class, we have talked about the position like occiput anterior or occiput posterior, occiput transverse. These all are different types of position. So whatever is there, we need to mention it. Station. Station means according to the ischial spine, where is the presenting part. If it is exactly at the level of ischial spine, we call that station 0. If it is above the ischial spine, okay, we call it -1, -2, -3. And if it is below than that, we call it +1, +2, or +3. This is called station. Okay. And then attitude. Now attitude means the posture of the fetus during labor, and the usual attitude is flexed one. That is, the head of the baby is flexing and touching the chest. So this is the normal attitude or flexion attitude. If the head is extended, then the delivery would be very difficult or even cannot occur. These are very, very important terms in obstetrics. Let's move on. We have to assess the contraction now. At least 10 minutes time, okay, would be given to assess the contraction. And during that time, what is the frequency of the contraction? How quickly are they coming? That is called frequency. What is the duration? How long are they lasting, each of the contraction? And how strong are they? So this is called assessment of the contraction. Remember, this is uterine contraction or true contraction of the uterus we are judging. And the most important next examination is fetal heart tone. So examine for the fetal heart rate. What is the rate? Okay, is it present or not? All these important questions are there. So what is the normal fetal heart rate? What is the normal one? Yes, what is the normal fetal heart rate? 120 to 160 beat per minute is the normal fetal heart rate. Okay, so if the fetal heart rate is between that, it's considered normal. If it is above or below than that, then we know the fetus is under some stress, and definitely less than 100 or less or more than 180 is abnormal. That is called fetal distress. Okay, let's move on. Now, so all of you, please pay attention on the screen. This is how we examine the fundal height. See there, fundal height. So one of our hand, okay, is examining that. So this is the epigastric region, and this is the huge distension of the abdomen because of the fetus inside. So this is how we judge the fundal height. It's quite easy. Now these are the different type of grip. We have talked about this before. If you remember, these are called Leopold's maneuver. Okay, the lateral grip, the fundal grip, the pelvic grip. There are different types. So see here, this is the fundal grip. Okay, so we try to find out what part of the baby is present near the fundus. That is done by fundal grip. And I already told you, or you already know, the cephalic presentation is the most common presentation. So the head is downward and the buttock is upward. Okay, so it is the one which is present in the fundus, fundal grip. In case of bridge presentation, the head is present in the fundus. These are the lateral grips. Okay, lateral grip. We palpate on the both side. We try to find out on which side is the back of the baby, which side are the limbs of the baby. Okay, and what is the position of the head. The position of the head is better told by the pelvic grip. Now see this, these are the pelvic grip. Okay, all of you I'm sure can see it. See here, this is how we judge the pelvic grip. This is a type of pelvic grip. On this, you know, the baby is, see here, turning on this side, and the other picture turning on the opposite side. So this is known by the pelvic grip. There is another type of pelvic grip as well. You can clearly see here. Okay, I want you to focus on this picture now. Okay, see this type of pelvic grip. This exactly tells us whether the head is engaged or not, or whether the head is still above the pubic symphysis or not. And what is the presenting part, that information is also provided. So these two, C and D, are called pelvic grip. Okay, B is the lateral grip, and A is called the measurement of fundal height, or you can also call it fundal grip if we use both of our hand to palpate the fundus. So all of these are called Leopold maneuver. Now this is auscultation, and this auscultation is mainly done for fetal heart rate or fetal heart tone. Now look at this instrument there. Can you tell me what is the name of this instrument which I am showing? This one.
Fetoscope.
Fetoscope, sir, fetoscope.
Very good. Yes, these are called fetoscope. These are fetoscope. They are very commonly used to listen for the fetal heart tone. And this is called handheld Doppler. This is the Doppler. Handheld Doppler, or you can simply call it Doppler. This will amplify the sound which is heard, and the sound is heard all over the room there. Every people who are standing or sitting there can hear the sound. Even the mother can hear that sound of her fetus. So this is Doppler. Now, another type of examination we can do is pelvic examination. Pelvic examination. Now, let's talk about it. This is a very important part of today's class. During pelvic examination, we have to judge how many centimeter dilatation of the cervix is already achieved. This is denoted in centimeter. What is the effacement of the cervix? This is denoted in percentage. What is the position and consistency of the cervix? So dilatation, how many centimeters cervix is dilated? Very easy to understand. Effacement, so many times we talked about. This is a softening, okay? Softening, stretching of the cervix. In other words, the cervix is pulled up towards the upper uterine segment. So there will be obliteration of the canal. The canal is no more there. If you remember what we discussed in the last class, before the proper effacement, the cervix is presented as a canal, but after the complete effacement, that canal is no more there, okay, and cervix becomes very, very thin. We should judge the position of the cervix. It should be at the center, and consistency, it should be very soft. These are the different points. Now, how to judge how many dilation or what is the effacement? This is done by per vaginal examination, PV, per vaginal examination. That is routinely done at the time of admission and routinely after that, probably every 4 hours. At the time of admission, we should also check for membrane, whether they are intact or ruptured. Now, how do we know the membranes are already ruptured? How do you know that? Yes?
Because of leading
amniotic fluid pass.
Exactly. Okay, every student can answer that, because amniotic fluid comes out after the rupture of membrane. Then only membranes are ruptured. Okay. Slight amount of blood may come even without the rupture of amniotic membrane. But if there is a sudden gush of fluid from above, then this is definitely the membranes are ruptured. One important point, when the membranes ruptured, but she has not ate, okay, in second stage of the labor, or not in the active stage, active phase of the first stage of labor, you have to exclude cord prolapse, because umbilical cord may come down before the presenting part, and if that happens, that umbilical cord may be compressed by the presenting part against the pelvic cavity, and the baby may die sometimes because of this complication. This is known as cord prolapse, so we must exclude it by per vaginal examination. If the membranes are still intact, okay, make sure there is a bag of water formed there. The bag of water, it is called. See here, we can feel it because the membrane are still not ruptured. After the rupture of membrane, check for the color of the amniotic fluid, whether it is clear, whether it is meconium stained or blood stained. Now, clear and blood stained are considered normal. There would be a slight blood stain in the amniotic fluid. We don't, be that much serious by this point. But if there is meconium in the amniotic fluid, we should take it seriously. Now, why? Why is that? Why passage of meconium in the amniotic fluid is not a good sign? Yes? Who can answer this?
Maybe chances of aspiration.
Good. There is a high chance of aspiration if amniotic fluid is stained with meconium, and if this meconium reaches the lung, it will lead to meconium aspiration syndrome. Good answer. And second point is, meconium is not passed, okay, inside the uterus until and unless the baby is having hypoxia there. So we already know baby was under hypoxic stress, then only meconium was passed. So if we delay in delivery of this hypoxic baby, the baby may die, or the baby may suffer from serious hypoxic injury. So these are some of the very important points you get from asking or examining the amniotic fluid color. Another point is, what is the presenting part? What is the position of that presenting part? What is the station, and what is the molding? We also know by doing pelvic examination or per vaginal examination. presenting part, is it bridge or is it vertex? Position. If it is vertex, we call it occiput anterior, occiput posterior, occiput transverse. Different terms are there. What is the station of the presenting part? It's zero station or plus or minus to that. And molding. Now, what is molding? Any student? What do you mean by molding? Anybody? This may be a new term for you, so let me explain this. Molding means the suture, okay? Sutures are not fused, isn't it, in the baby? Sutures are not fused in the baby. They are actually a bit separated. So when the head is coming downward, the skull bones or the cranial bones are overlap with each other. The cranial bones, okay, overlapped with each other. Overlap with each other, so that the overall diameter becomes smaller and head would be easier to come out. This is called molding. So let me explain again. When the head is trying to come out, because the sutures are well separated, they are not fused, the bones overlap with each other, so the diameter of the presenting part would be smaller than before. This is called molding. So we can find it out by pervaginal examination. Another important part of pervaginal examination is assessment of the pelvic capacity. Now, I will talk in detail regarding this. That means whether the lady will be able to deliver the baby normally or not. What is the capacity of the pelvis? Can the baby pass through that pelvic cavity or not? This is called assessment of pelvic capacity. There are different diameter we are going to check. Okay, what is the diagonal conjugate of the pelvis? What is the interspinous? What is the interspinous diameter of the pelvis? Interspinous diameter it is called. That is probably the smallest diameter which is present in the pelvic cavity. What is the diameter of pelvic outlet? So all these things will be judged in pelvic capacity. Okay, in the subsequent slide we are going to talk about that. What is a normal position? We already explained. And what is the station? Is it 0 or is it more than that? Means it is towards the plus. So let me remind you again, if it is towards the plus or below the ischial spine, okay, we call it plus 1, plus 2 or plus 3. And if it is still above the the ischial spine, then it is denoted as a minus sign. Now, see here, okay, these are the points which you already know, but this topic is such an important one, so that a lot of repetition would keep on coming here. Cervical dilatation. Now, how to judge? Let's talk a little bit practically. We cannot measure it, isn't it? We cannot measure by a measuring tape there. So how to do, or how to know how many centimeter of the cervical dilatation is there? Remember, we are talking about pervaginal examination now. It is denoted by how many fingers you can insert into the cervical canal, okay, or the external os of the cervix. So accordingly, you can find out how much centimeter the cervix is dilated. Now, first of all, let's see at this picture. See there, please. See here. In this, picture, there is no effacement and no dilatation of the cervix. So this is the external os. Here is the vagina. This is the cervical canal. Every student can see. Okay. So there is no effacement. The cervix has not get thinner. Okay. It has not drawn up. So no effacement, no dilation. we can find it out by per-vaginal exam. You see this? The cervix is fully effaced. This is called effacement. Just compare this appearance with this appearance. This is fully effaced, but only slight amount of dilation. Okay, very slight amount of dilation. In this, it is fully effaced and a bit more dilated than before. Okay, and here the cervix is fully dilated. That's why the head starts to come. But another good question is how to judge this cervical dilation. Now let's talk about that. See this. Okay, this is important practical information or knowledge for you. If you can put one of your examining finger inside the cervix, then it is 2 centimeter dilated. Okay, this is the rough estimate. If we put 2 finger inside the dilated cervix, it is around 3.5 centimeter dilated, or 1/3 of the total dilation. If you can separate 2 of your finger, okay, see that there is a gap, so we believe the 3 fingers can be adjusted there. It is 5.5 centimeter or half dilated. You can say 5 to 5.5 centimeter, because the total dilation is 10 centimeter. Okay, so if you put fingers like this, then 7.5 centimeter. So this is the way by which we judge what is the total dilation of the cervix. What is the maximum dilatation of the cervix? Yes, how much
10
centimeter?
centimeter.
10
10
centimeter. 10 centimeter.
centimeters.
10 centimeter.
Exactly, the maximum is 10 centimeter. Okay, so this is the way you can judge, or you know how much cervix is dilated. This is very, very important practical information. Now, the thing which I was talking a little while earlier, how to assess the pelvic capacity. Now, see here. Please pay attention. Actually, these all are the important parts of your obstetrics practical classes. Okay, but right now we cannot conduct any practical classes, so I have included these important things in the theory classes itself. Whenever there is time, we can always talk about practical later on. So this is the pelvic cavity here. So see this? This is called sacrum. Okay, this is the sacral bone. The uppermost part of the sacrum is called sacral promontory. Sacral promontory. This is a very important landmark. Okay. These are the other sacral vertebra, and this is the coccygeal vertebra. Now, this is the pelvic bone. Okay, pelvic bone. We have 2 pelvic bones on either side. 1 on either side, I should say. So pelvic bone has got 3 parts. Ilium. Okay, this is ilium. The posterior one is called ischium. Ischium is posterior, and this is the pubic bone. Okay, pubis. So ilium, ischium, and pubis. This is called symphysis pubis, which is present exactly in the midline. This is pubic crest. This is the ischial spine here, and this is called iliopectineal line. These are the important anatomical landmark in the pelvis. See here, this is called anterior superior iliac spine. Every student know that. The posterior superior iliac spine is here on the posterior side. Okay. Now, what do you mean by the true conjugate? True conjugate. Now, see here in this picture now. This pink line, okay, this pink arrow is telling us this is called true conjugate. So on the back side, it starts from sacral promontory, and in the front side, it is okay starting from the upper part of pubic symphysis joint. See here, between these 2 points is the true conjugate. Now, obstetrical conjugate means the middle part of the symphysis pubis anteriorly and posteriorly to the sacral promontory, and the diagonal conjugate the longest one anteriorly the inferior border, okay, or the inferior surface of symphysis pubis, and posteriorly in the sacral promontory. Now, if you analyze them properly, okay, these are the diameter of pelvic inlet. Pelvic inlet. So the baby has to cross, okay, this part, then only the head or the presenting part will enter into the pelvic cavity. So these are the diameter of the pelvic inlet. The true conjugate 11 centimeter, the obstetrical conjugate is 10.5 centimeter, and the diagonal conjugate is 12 centimeter. This is the normal measurement in a gynecoid pelvis or the female pelvis. So let's move on. There are so many other types of diameter as well. Now, when we enter into the pelvic cavity, okay, some other types of diameters are there. This is the transverse diameter, okay, of the inlet. This is the transverse diameter of the pelvic cavity. So it is 10 centimeter now. See here, ischial spine, between two ischial spine is called interspinous diameter. It is 10 centimeter, and this is the narrowest diameter of the pelvis. The baby has to pass through it, then only the baby can be delivered. If the female pelvis is having interspinous diameter of less than 10 centimeter, delivery cannot occur. Okay, so during the obstetrical examination, the obstetrician has to judge what is the interspinous diameter as well. And another is the pelvic outlet diameter. It has got two parts, antero-posterior diameter and the transverse diameter. The transverse diameter is between two ischial tuberosity. This is 11 centimeter, and the anterior-posterior diameter is, okay, around 12.5 to 13 centimeters. So this is about the pelvic outlet diameter. Before the break, we're talking about the different diameter of the pelvis. We talked about what is the diameter of the pelvic inlet, what is the diameter of the pelvic cavity, and what is the diameter of the pelvic outlet. So let me quickly revise again. Regarding the pelvic inlet, okay, diameter, we check diagonal conjugate during the obstetrical assessment, or during pelvic assessment I should say. The normal diagonal conjugate is around 12.5 centimeters. Regarding the interspinous diameter, which denotes the pelvic cavity diameter, it is 10 centimeter. And regarding the pelvic outlet, you can clearly see here the diameter between two ischial tuberosity is around 11 centimeter. Okay, now these are very, very important diameter. They has to be normal, then only the baby can come out from that pelvis. Now, one important point which must come in your mind: why are we checking this type of diameter, isn't it? The answer is, if the diameter is less, the baby cannot be delivered. That is called cephalopelvic disproportion, CPD. Cephalo is head, pelvis is pelvic cavity. Disproportion, they are not matching, the size is not matching with each other. So CPD, or cephalopelvic disproportion, and this is a strong indication for cesarean section delivery, because the head cannot come out. So how the delivery or normal delivery is possible? So to know this, the obstetrician will do pelvic capacity examination. Now see here, let's talk a little bit of a practical thing. This is how the assessment of pelvic capacity is done. This is the diagonal conjugate. So lower border of the symphysis pubis till the sacral promontory. This diameter is diagonal conjugate. It is quite easy to judge, okay, in that pregnant lady. Now this is even better picture. Okay, all of you please focus here. See this. So let me use the pointer here. So here is the examiner's hand. This is for vaginal examination. Okay, you should insert 2 fingers into the vagina and then examine. Now see here, this P is the sacral promontory. So the finger is touching that now, and on the other side here, this is S. This is called symphysis pubis joint. So the lower border of the symphysis pubis. So this diameter is diagonal conjugate. Okay, it is around 12.5 centimeter, and that is normal. This is the judgment of prominence of the ischial spine or interspinous diameter. So we should, extend, or we should move our finger away from each other, these 2 fingers, and if they, nicely touch the ischial spine on either side, then the interspinous diameter is normal. Now this is the pelvic outlet diameter judgment. So see this? This is called ischial tuberosity. Okay, this is the main part which forms the buttock actually. This area is covered by a lot of gluteal muscles. Okay, so these 2 ischial tuberosity distance is measured for the pelvic outlet. So these are the different points we have talked till now. So let's proceed further. After knowing all these anatomical diameters, let's talk about how to manage the first stage of labor. Now, first stage of the labor is divided into 2 phases. Every student know that by now. The first phase is called latent phase, and the second is called active phase. The latent phase starts from the onset of labor until the cervix reaches 3 to 4 centimeter dilatation. Some books mention 4 centimeter, some books mention 3 to 4. So whatever your answer would be correct, 3 to 4 centimeter dilation. Okay, it is not the exact value there. In primigravida, it lasts much longer, and in multigravida, it lasts a bit shorter. So the average duration is around 8 hours, and some lady it may be longer as well. In this latent phase, the uterine contraction are at least 2 for every 10 minutes. Okay, means 2 contraction in 10-minute examination. So this is, okay, the total duration of each of the contraction, or frequency of the contraction, you can say. This is frequency, and here is the duration. So each of the contraction lasts less than 20 seconds. This is the duration. This is the frequency. In 10 minutes, how many contractions are coming? So there should be at least 2. So this is in latent phase. Now, what happens in active phase now? Active phase of the first stage of labor. Now, please focus here. The cervix should dilate at a faster rate now. Okay, it should dilate at a faster rate. After 3 to 4 centimeter dilation, till it reaches 10 centimeter, the cervix dilate at around 1 centimeter per hour rate, or in multigravida, even 1.5 centimeter per hour rate. This is important point. And the contractions also occur, okay, at a higher frequency. See here, 3 times for every 10 minutes, and each lasting less than 40 seconds. Earlier, it was less than 20 seconds. Now, less than 40 seconds means they are lasting longer than before. They are getting stronger than before because the labor is in active phase now. Okay, this is the meaning. Now, all of you, please focus on this picture now. This is highly informative one. In early labor, okay, there is not much pain. There is pain, there is labor pain, but the lady can tolerate it easily. When she enters into the active labor, okay, active labor, or this is the active phase of the first stage of the labor, the pain substantially increases. Look at the facial expression here. There is a phase known as transition phase. When the cervix is almost completely dilated, the pain is too much, or the pain is unbearable now. Labor pain. is one of the most severe type of pain a lady can experience. And during the pushing also there would be severe pain. Okay, so active phase is a painful process. Now this slide is talking about, see here, what is effacement and what is dilation of the cervix. So many times we have discussed this before, but this is such an important practical class for the obstetricians. We need to talk it again. So this is how the closed cervix looks like. Okay, this is schematic diagram. Okay, and here is a very nicely explained. This is the meaning of effacement: the gradual thinning, shortening, and drawing up of the cervix, and it is measured in percentage from 0 to 100. So see this. In this condition, the cervix is not effaced. It has effaced or started to efface, and here, okay, it is completely effaced. Look how thin it is. Okay, and where is this cervical canal now? It is no more seen here. So this is called effacement, and this is the dilation, the gradual opening up the cervix. See here, from 1 centimeter till 10 centimeter. Okay, this is dilation, and we need to judge it by per vaginal or digital examination. We already talked it about. If one finger is inserted, it is probably 2 to 3 centimeter. Okay, and how much wide we can make our finger there, that is how we judge cervical dilation. Let's move on. Now, another point, this is a bit of repetition for you, is the molding. See here, molding of the fetal skull. Now, I already explained molding is a overlapping of the skull bone or the cranial bone, because the suture, which is the joint between this cranial bone, okay, is having a wide gap there. Okay, it is not fused at all during that time, so the bone can easily overlap with each other, so that the total diameter of the presenting part would be less, and that will make the delivery easier. Increasing molding with the head high in the pelvis is an ominous sign of cephalopelvic disproportion. Now all of the students, please focus on this line. This is very important. Okay, a practical problem. If there is excessive molding already occurred when the head is not engaged, the head is still very high in the pelvis, that is a clear-cut feature of cephalopelvic disproportion, means head is not entering at all into the pelvic cavity. That means what? The diameter of the pelvis is lesser than the total diameter of the head, and this is known as CPD, or cephalopelvic disproportion. Now, can the lady deliver in this condition? So what type of delivery we should go for in CPD, in cephalopelvic disproportion? What is the alternative type of delivery now? Yes, what should we do? Anybody? This is delivered by cesarean section. Okay, it is delivered by cesarean section because normal delivery is impossible now. Now, during examination, if the separated bones are there and sutures felt easily, this is zero molding. If bones are just touching each other, this is +1. If there are overlapping bone, +2. And if there are severely overlapping bone, which are quite notable, then 3+ molding. And this is a good amount of molding which is present there. Now, one last sentence before I move further. Molding is a normal or natural process when the head is descending down. Okay, it should happen, but if it occurs when the head is still high in the pelvis, then it is a feature of cephalopelvic disproportion. Okay, got it. I was unmuting you because of some students. I did that and forgot to unmute you again. Okay, now I've done that. Fine. Let's move further. Okay, now see here. Now this slide is telling us about the progress of labor. Now progress of labor is judged by so many different parameters. One is cervical dilation, which we have just talked about. In the latent phase, it reaches about 3 to 4 centimeter, and in the active phase, it will start from that 4 centimeter till the 10 centimeter. We have done that before. Now, the descent of the fetal head is also judged by the see this station. Now, when the presenting part is at the level of ischial spine, this is station 0. Above this, we call it minus station, and below that, we call it plus station. It is also judged by the pervaginal examination. When there is a progress of labor occurring, okay, the fetal head should gradually descend down because of uterine contraction. Then only we can say, yes, the labor is progressing well. On the other hand, if the labor pain is there, if the uterine contraction is very strong, but the head is not descending down, okay, there is something horribly wrong. Probably the size of the pelvis is narrow. And this is another important point about cephalopelvic disproportion. Now, another way of judging the descent of the fetal head is by the rule of fifth, which we do during abdominal examination. This point we have already explained. Now, let's revise once again. During the Leopold's maneuver or during the abdominal examination, if head is mobile above the symphysis pubis, if it is freely mobile, if I can grip the whole head with one of my hand, then okay, it is 5 by 5. It has not entered into the pelvic cavity at all. Now see this. The other one or the other way is all of my 5 finger, okay, are accommodated by the head. Means the head can accommodate all of my 5 finger or all of the examiner's 5 finger above the symphysis pubis. That also means the fetal head is still not entered into the pelvic cavity. On the other hand, see here, head is 2 by 5th above the symphysis pubis. How I know that? Only 2 fingers are accommodated above the symphysis pubis, and that is called 2 by 5th. So this is one of the way to know the descent of the fetal head by abdominal examination. Now, if your examiner asks, what is the other way of knowing the fetal descent? You can always answer, okay, the station. And that station is mainly judged by pervaginal or pelvic examination. Now, that's what, okay, we have talked just now. 0 station is at the level of ischial spine. Above that, minus. Below that is plus station. And this is judged by the pervaginal examination or pelvic examination. Now, another, a picture which is telling you the same thing. Okay, this is a schematic diagram, but very, very informative one. See here, this is the pelvic cavity. These are the pelvic bone. This is, okay, ischium. This is pubis, and this big bone is the ilium. So see here, okay, this is between the ischial spine. So fetal head is at -1 station because it is a little bit above the ischial spine. So -1 station. So this is the meaning. Now, let me ask you one question. What is engagement? Yes, what is engagement? Who can answer this?
Sir, This is when the large diameter of the fetal head descends into maternal pelvis.
Very
Descend
good.
down to the
Yes, please. Yes, yes, Junaid. Go on. Yes.
engagement sir, when the largest diameter of fetal leg fits into the largest diameter of the maternal pelvis.
Good. Okay. Good. Good. So many students know this, and I'm sure, okay, this is an easy question at this time because we have repeated it so many times. Now focus here. If somebody cannot still answer, the answer is provided by this picture. So here, see here, please. This is biparietal diameter, the largest diameter of the fetal head. Biparietal diameter. If this biparietal diameter has entered into the maternal pelvis, we call it engagement. I'm making it very easy for you. That means the largest diameter of the presenting part has entered into the maternal pelvis. This is called engagement. Now see this, in this picture it is still not engaged because this is biparietal diameter and this is the pelvic inlet diameter. Pelvic inlet diameter, it has not crossed, so it is not engaged. Whereas in the other picture it has crossed, so it is properly engaged. This is the important point. And on the other side they are again showing the station. Station 0 means when the fetal vertex is at ischial spine. Now I want all of you to focus on this graph. Okay, take a few seconds time and focus on this graph, please. What you understand by this graph? Can anybody explain me about this graph? Yes, who can?
Sir, in this graph, sir, it is showing, sir, that sir, the time for the on the pares basis, sir, in which the cervix is dilated. Like, sir, for the primary pares, sir, it is, sir, in 13th hour or 13th to 14th hour when the 10 centimeter cervix, that sir, that ultimate dilation is reached. But sir, in the multi-pares, like, sir, it is reached in that 7 hour, that ultimate, sir, that 10 centimeter cervix dilation, which is the most ultimate part of it.
Good, very good, very well explained. Good. Now see there, this is very obvious, isn't it? Very, very obvious. This is the time taken for the cervical dilation in the x-axis and in the y-axis. Okay, this is the total cervical dilatation, and the maximum dilatation is 10 centimeter. We all know that. This is the amount of time taken in multiparous and primiparous. So primiparous, it is taking a long time to reach that 10 centimeter. Okay, according to this graph, almost 13 hours. And in case of multiparous, see here, it is taking just 7 hours. Okay, so this is the difference between multigravida or multipara and primigravida or primipara woman. Let's move on. Now this is the same slide which we have shown in the beginning. In the latent phase, okay, it may reach up to 3 to 4 centimeter dilation, and in the active phase it reaches up to 10 centimeter, and then only the second phase or second stage of the labor will start. Now, how to assess the progress of labor? This is the point which we have discussed, or we are discussing till now. So let us, okay, put all those discussion in a good way, so that if this question is asked in the exam, you know how to answer. See here, please focus. Once diagnosed, progress of labor is assessed by measuring the changes in cervical effacement and dilation during the latent phase, and we all know how to do that now. Another point, measuring the rate of cervical dilation and fetal descent during the active phase. Both of these phases are in first stage of the labor. That's what we are talking right now. This thing is done by vaginal examination, also known as pelvic examination. Okay, we put two of our finger into the vagina of that pregnant lady and try to examine these things: cervical effacement and cervical dilation, how much fetal head has descended down according to the station. It has to be done at least once every 4 hours during the first stage of the labor and after rupture of the membrane. So once every 4 hours. Okay, this is important point. Not too often and not too late also. Once every 4 hours. Remember this. At the same time, we need to examine a record. What is the temperature of that lady and what is the blood pressure? What is the pulse rate? Of course, all the vital signs would be recorded. Contractions would be recorded every 30 minutes. And urine should be examined for protein as well as ketones. These are some other important part of the examination, but they are less important than this vaginal examination at this time. Now, a bit of practical information again. This class is mainly practical rather than theoretical. Which are the criteria which tells you there is satisfactory progress in first stage of the labor, so that we are quite happy to wait till the lady enters into the second stage? So we should know about those point. And those points are regular contraction of progressively increasing frequency and duration. Means each of the labor pain is getting more frequent and more severe, and it will last longer than before. Then we are quite satisfied. Yes, the labor is progressing quite well. Another thing, the rate of cervical dilation at least 1 centimeter per hour during the active phase of labor. In primipara, but in multipara, it may be 1.5 centimeter per hour as well. Another important point, cervix is well applied to the presenting part. That means the fetal head is descending down, or the presenting part is descending down. I use the term head because head is the most important presenting part, okay? But not always. Sometimes the breech is the presenting part. So this is the important point. So three things: regular contraction, progressively increasing in frequency and duration, the rate of dilation 1 centimeter per hour, and cervix is well applied to the presenting part. On the other hand, if these things are not there, then there is unsatisfactory progress to the first stage of the labor, and that means this is a case of prolonged labor. Now, what is the danger of prolonged labor? Yes, what is the danger?
Hemorrhage, sir.
Sir, hemorrhage will occur, sir.
Hemorrhage.
Okay, hemorrhage. Then anything else?
Sir,
Now,
hemorrhage may lead to hypovolemic shock.
okay. Now,
Due to prolonged labor, may be complication to baby due to compression and contraction of the uterus.
exactly. Okay, you
Sir,
should always.
fetal distress
Yes,
can occur, the fetal distress.
exactly. So now listen here. Okay, the answer is quite correct. You should always think about both mother and the fetus. There is some problem in the mother. Mother will exhaust because she's constantly having that contraction. This is a difficult thing for the mother. This is first thing. And second, the fetus is constantly getting that compression from the uterus side. And sometimes what happens? The amniotic membrane is already ruptured. So the amniotic membrane is already ruptured, and then there is a prolapse of the umbilical cord. So if labor is very prolonged, then that umbilical cord may be compressed between the presenting part and the pelvic cavity, and it may lead to death of the fetus also. You are absolutely correct. The fetus may get hypoxia from a prolonged labor. And then somehow if the labor occurs because of prolonged state of the uterine contraction, later on the uterus may develop inertia. This is called uterine inertia, and that is very, very important point for postpartum hemorrhage. During labor, hemorrhage doesn't occur, but after the baby is delivered, in the third stage of labor, there may be massive amount of blood loss. So all of these can happen because of prolonged labor. Let's move on. Now, how to judge the progress of fetal condition now? So in between, we need to examine the fetal condition as well. And one important way of examining the fetal condition is hearing the fetal heart rate, either by a fetoscope or by your own stethoscope or by Doppler, or sometimes there is a special machine or instrument which is called cardiotocograph, okay, CTG. Now here, if there are fetal heart rate abnormality less than 100 per minute or more than 180 beats per minute, this is called fetal distress. This is not normal, because the normal fetal heart rate is between 120 to 160 per minute. This is normal. So if it is either above than 180, okay, or below than 120 or 100, to be very frankly 100, because 120 to 100 is still that baby can manage somehow. But if it is less than 100, the baby cannot manage, and that is sure a short sign of a fetal distress. Now please remember the normal value here. Another way to find out the progress of fetal condition is by position or presentation, okay, other than occiput anterior with a well flexed vertex are considered malposition or malpresentation. So let me remind you once again, occiput anterior and well flexed vertex are the normal position or presentation, and you can also call it attitude. The well flexed vertex is called flexion attitude, that is considered normal. All other positions apart from occiput anterior are malposition or malpresentation. If unsatisfactory progress of the labor occur, then we have to manage it. Okay, what is the cause of the slow progress? Why? Maybe there is very slow or ineffective type of uterine contraction. Maybe there is a narrow pelvic cavity. What is the reason? We have to find out and manage accordingly. Now, this, every student know, but this is a very important question in your exam. How to evaluate fetal well-being means how to measure or hear fetal heart rate. So only two important things are shown here. One thing you already know, that is fetoscope, okay? Don't forget that. Another is your own stethoscope. It is always there. But we usually go for fetoscope than our stethoscope. Fetoscope is a specific instrument to hear fetal heart sound. In this condition, this is known as Doppler, handheld Doppler, and this is called cardiotocograph. Okay, cardiotocograph, and this is just like a recording of a fetal heart rate, just like ECG. We are recording, the person's or the patient's heart rate. We are monitoring the fetal heart rate, cardiotocograph. And another thing, look for the color of liquor or color of amniotic fluid. Every student know the normal color is clear. If it is stained by meconium, it is always abnormal, especially in vertex presentation. In breech presentation, there is an exception, okay? Please listen. In breech presentation, it may be considered normal. But in cephalic presentation, it is always abnormal if the baby has passed meconium, okay, before the delivery. Now, there may be reason here. The meconium is passed only inside the uterus if the baby is under hypoxic stress because of the compression of the head, because of a compression of the umbilical cord, which may be prolapsing between the head and the pelvic cavity. All these reasons are very important for the passage of meconium inside the uterus. Now, how to see the progress of maternal condition now? Okay, see here, this is also very important. Evaluate the woman for signs of distress, like if the woman's pulse is increasing, she may be dehydrated or in pain. This is a prolonged process, isn't it? Already 8 hours may have been passed from the time she was admitted, or even longer than that. Okay, she is having constant pain, so she may not be drinking any fluid, or she may be getting very less amount of IV fluid. So she is dehydrated. So please judge all these things and ensure the adequate hydration either via the oral route or IV route. This is very important one. If she is having excessive pain, provide adequate analgesia that can be done in the hospital. And which type of analgesia you like to give? Any answer? Which analgesia? Anybody?
Lidocaine.
Painkillers.
Like what?
Paracetamol. Paracetamol.
Now, okay, this may be a bit of practical question for you. During labor, one of the important drug you can give is pethidine. Pethidine is an opioid analgesic that can be given, and another is called epidural analgesia. Epidural analgesia. We inject some of the opioid analgesics into the epidural space, and that can take care of the pain. If the woman's blood pressure decreases, suspect hemorrhage. Definitely, that's why blood pressure should be measured time and again. This may be a case of severe hemorrhage. If acetone is present in the woman's urine or breath, I should write breath here rather than urine, because acetone is mainly present in the breath. But acetoacetate may be present at the same time in the urine. Okay, suspect poor nutrition, and during that time give dextrose containing IV fluid. Probably she is starving for a long time, so we should give a bit of nutrition to her, and that is provided by dextrose containing fluid. So let me repeat again. Once one type of ketone body is formed, the other types of ketones are also present in that woman's body. Isn't it? It's quite easy to understand. Is what are the supportive care we should provide during labor and childbirth? Now see here, we should encourage the woman to have a personal support from a person of her choice throughout the labor and birth. In many Western countries, okay, the husband would be present in the delivery or labor room, the husband. But in the Asian countries, okay, usually nobody is present there. That is what we have seen. Nobody. Only the lady would be present there. If she wishes a person to be present there with her, probably it's her choice, maybe her mother, maybe mother-in-law, okay, maybe somebody else, whoever she chooses, sometimes even the husband. That person should accompany her, next to her, and the person should give a lot of moral support, a lot of encouragement for her. This is very, very important point. The person should rub her back, wipe her brow with a wet cloth, and assist her to move around in the delivery room till the second stage of the labor. Let's move on. Now, another important point is ensure good communication and support by the staff. So the lady, especially if it is the first time, the lady is terrified. Okay, this is a very painful type of experience for her. So we as a doctor or the nurse or healthcare worker should explain all the procedures, should seek permission from her and discuss the findings with the woman. What is happening? Is the progress happening well or not? Everything should be discussed, and provide a supportive and encouraging atmosphere for the birth. At the same time, ensure privacy and confidentiality. If the lady doesn't want something to share even with her family, okay, we must respect her feeling. This is called confidentiality. This is very, very important point. Now, I like to give you one important example here. Sometimes there may be slight amount of congenital anomaly which is present in the baby, and when we share this thing to the mother may not want this thing to be known by her family member. We must respect her feeling. This is called confidentiality. Okay, you should not open up the discussion among the family member. Another important point: maintain cleanliness of the woman and her environment. You see this? Encourage the woman to wash herself or bath or take shower at the onset of labor if she wish. Wash the vulval and perineal areas before each examination. This has to be done, otherwise there is a high chance of infection. Wash your hand with soap before and after each examination. It is for your own good. Ensure cleanliness of labor and birth area, and clean up all spills immediately. If some blood, if some fluid, whatever is trickling down, you should clean this or remove this immediately. Okay, so these all are important supportive care during labor and the childbirth. Now, what are other supportive care we must provide during labor or the childbirth? Now, let's talk about it. Ensure mobility around the labor room. Before second stage of the labor, the lady can nicely move around. Now this will help in the descent of the baby because of the effect of gravity, and it is good for the lady as well. She should not lie in one position all the time. Support the woman's choice of position during labor and birth. Now later on we'll talk about there are so many different positions the lady can attain for the delivery. We'll talk about that. So it's her choice and we should respect her feeling. Encourage the woman to empty her bladder regularly. If there is full bladder, the descent of the fetus is a problem. The delivery is a problem. So bladder should be emptied regularly. Do not routinely give an enema to the woman in labor. Only if she is having constipation. Okay, if we believe, if she suspect that, then only we give the enema. Now, what is enema? What do you mean by that? Enema means what?
Through rectal routes.
Exactly, to give some medicine through the rectal route for the passage of stool or for the passage of fecal matter. This is called enema. Okay, we don't need to give it routinely. Encourage the woman to eat and drink as she wishes. Now we are talking about the first stage of the labor, remember that. So in this stage, if the woman wish to eat or drink, we should allow her, especially if the woman has visible severe wasting or she looks very tired during labor. Make sure she is fed well, especially some liquid. Okay, some highly nutritious liquid should be fed like a soup. That would be nice. Another important point which are discussed under supportive care during labor and childbirth are, it is a breathing technique for labor and delivery. Now this is a very difficult process for her, we all know that, and she should take a very long breath and quite a slow type of breath rather than faster breathing. So encourage the woman to breathe out more slowly than usual and relax with each expiration. So this is called breathing technique for labor and delivery. Now, many of the women are anxious, they are afraid, or they are in a lot of pain, especially in case of primipara. This is what happens. So we should give her a lot of praise, encouragement, and reassurance. Okay, we should increase the morale of that lady. Nothing will happen. All of so many of the ladies like you have delivered the baby, okay, without any problem. So we should increase the morale. Give her a lot of information on the progress of her labor, and we should listen if she want to say something. Okay, this is showing the sensitive nature of ours towards her. If she is trying to share something, we must listen to her. Now, if she has too much pain, if she is distressed by pain, what should we do? Okay, this is very important information. Now see here. Suggest change of position. Sometimes it may help. Encourage the mobility around the delivery room. It may help. So let me go a bit of slowly. So change of position we talked about. Encourage the mobility around the delivery room. Encourage her companion to massage her back, okay, or hold her head and sponge her face between the contraction. This soothed her. Okay, this is a soothing type of thing the companion can do. If companion is not there, a nurse, okay, or some of the helper should do that. Encourage the breathing techniques. Just now we talked about long, okay, type of breathing and quite a slow breathing. Encourage warm bath or shower if she wishes. This is also decreasing the anxiety and again relieving a bit of pain. But if there is a severe pain and if she wishes to decrease that pain, we can give pethidine. Now, what is pethidine? What type of drug is this?
A type of
It is
morphine.
opioid and sir, it is from the
Painkiller.
phenylketonuria class.
Painkiller.
Opioid analgesic.
Okay, good. Very good answer. Okay, you should say this is a painkiller. Very nice. And for the classification, this is opioid analgesic. Excellent. So opioid analgesic type of painkiller. So pethidine, 1 milligram per kg body weight, but we should not give more than 100 milligram. Can give it IM or IV. Okay. Or if pethidine is not there, we can go for morphine also. But remember, pethidine is always preferred over morphine at this time. Okay, now let's move on. Now, another important point is, what is the role of ambulating and position change in labor? What is the significance of this? Why we should encourage this? Walking may be more comfortable than being supine during early phases of the labor, because if the lady lies in the supine position for a long time, okay, there is one problem which is happening, that is called supine hypotension syndrome. We have discussed this before, because the gravid uterus will give pressure to the inferior vena cava, and if it is compressed, the inferior vena cava is compressed, what will happen? What will happen if inferior vena cava is compressed? Yes?
It may cause ascites,
Decreased pressure which
hepatosplenomegaly.
consistent hypotension occurring on there.
Okay, good. Now listen carefully, okay? If it is compressed for a long time, then only those things which you are saying will happen. Long time, chronic type of compression, like ascites, isn't it? Edema, even splenomegaly, all those things will occur in chronic type of compression. but she will constantly change the position, isn't it? She will be uncomfortable to lie in that supine position for a long time. That's why this type of complication do not usually occur. But your answer is well acceptable. Okay, very good concept. Now, so another important point is decrease venous return. You should remember this also. When inferior vena cava is compressed, there will be decreased venous return towards the heart, and decreased venous return will lead to decreased cardiac output. So all those things are there. So she should constantly changes the position, and the left lateral position would be fine, or constant walking would be fine. Now, all of you, please focus on your screen. Now, see here, these are the different types of positions. See this, walking, okay? This is sitting or leaning forward. This is tailor sitting position. This is called semi-recumbent position. This is kneeling position. Here is a standing position, okay? The person is giving her support from the backside, okay? This is squatting position. It's a choice. We have already discussed this. Whatever position she feels comfortable, she can attain that. Okay, squatting position is this. This is kneeling and leaning forward. This is called lithotomy position. We'll talk about this. It's a very important position during labor or delivery. Lithotomy position. So all these are a different one. Now, in late first stage, okay, what we do, how we identify she is in the later phase of the first stage of labor, and what we do during that time. Now that lady, okay, has urge to push in the later phase of the first stage of labor, means she has entered into the second stage of the labor probably, and in this phase there is significant descent of the fetal head, and that fetal head will give pressure on the perineum also. Now, one small question I like to ask immediately here. You have done that so many times. How do you know fetal head has descended down? How do you know that? Yes?
By
By
abdominal
fetal
palpation.
table examination.
Good. By per vaginal examination. So that is known as station, isn't it? Station. Okay.
Yes.
You have to say that particular term. Station 0 means the presenting part is at the ischial spine. Never forget this. So when the presenting part descend downwards from the ischial spine, we add +1, +2, or +3 according to each of the centimeter descent. +1, +2, or +3. And when the presenting part is above the ischial spine, we call it -1, -2, or -3. So this is the perfect way of knowing the fetal descent by per vaginal examination. Another one is also there. It is done by abdominal exam. You just feel in the suprapubic area how many of your fingers are accommodated in that fetal presenting part. This also tells you whether the head has engaged or not, or whether the presenting part has entered into the pelvic cavity or not. Okay, so this is a very important point. Let us move on. Now, after this, the lady has entered into the second stage of the labor. So let's talk about this. What should we do in the second stage of the labor? What type of management has to be done? Now, see there. First thing is the diagnosis of the onset of second stage. We should make sure the lady has entered into the second stage of the labor. Now, how we know that? See this? There is a feeling of desire to evacuate the bladder or rectum. Now, why is that? Because the descending head will give compression to the bladder or rectum. So she has urge to defecate or urinate. Important point. She has a desire to bear down during contraction. That is called pushing. She shows that desire. If we feel on the anterior abdominal wall, the uterine contraction are more prolonged and vigorous now, okay? Because this is the second stage of the labor. And how the baby comes down? The most important force is uterine contraction. So it has to be more prolonged and more powerful. And another very important point is the cervix has to be fully dilated, that is 10 centimeter. And this is the surest sign that the lady has entered into the second stage of the labor. And in the last class, we have talked about how to judge the cervical dilation. It is again by per vaginal examination. Okay, you should separate those two fingers and as far as possible. And if you can feel the circumference of the cervix by those two wide apart fingers, then it is fully dilated. Now, when the lady has entered into the second stage of the labor, what should we do now? We should transport the lady to the delivery room. Delivery room is a separate room, okay? Only in the second stage of the labor, the lady is transported there. In the first stage of the labor, the lady is waiting in some other room. So this is important point. Now, what is the position for delivery? This is the first important knowledge. The most commonly employed position is called lithotomy position. Now, let me explain this for you. Lithotomy position. Let's see this. Now, this lithotomy position is mainly employed for delivery of the baby or during pelvic examination or pelvic surgery. So during this position, the lady lies supine on the bed. Then what we do now, we'll flex the hip, okay, with legs a bit wide apart, and the legs are supported. So this is lithotomy position. So later on, I have collected few of the picture. I'll show you. Second important, dorsal position is also, employed sometimes, but lithotomy is much common than that. The second important role of the doctors or the nurses who are there in the delivery room is paint the vulva or perineum with antiseptic solution. That area has to be, made aseptic with antiseptic solution. Like, what are the examples of antiseptic solution? Anyone? What are the common example?
Iodine.
Iodine. Good. Yes, you're absolutely correct. Okay, Abbas, very nice. This is povidone iodine. Okay, povidone iodine. This is very commonly employed. You will see this when you enter into the labor room or delivery room, especially during internship.
Isopropyl alcohol, sir.
Exactly, alcohol is another one. You're right, alcohol is another one. Alcohol and iodine, these are very commonly used. During the internship, if you are interested, okay, you will be posted in the delivery room and you can see these things. Another important point is apply sterile leggings and towels there. Okay, they are already available. You just need to apply them there. Okay, just need to apply them there. Evacuate the urinary bladder by catheterization if not evacuated before. Now, there are different types of catheter. Probably you may be knowing this. One is called Foley's catheter. Okay, Foley's catheter. This is known as self-retaining catheter. Now, during this time, Foley's catheter may not be wanted because we just simply needs to drain the urine and take the catheter out. So simple plain rubber catheter may be necessary here. Just evacuate the bladder and remove the catheter. That's it. You don't need to put the catheter there. Ask the lady to bear down. This is the second stage of the labor. So she should push now. She should bear down during the uterine contractions and she should relax in between. She should not push all the time. Otherwise, she will be very tired. Okay, so the person who is there should teach her how to do that. and one very important drug is oxytocin. Now you all know the role of oxytocin here. What is the role? Why we give oxytocin here?
Contraction.
Exactly, to increase
Uterine
the
protection.
uterine contraction. Very good. To increase the uterine contraction, oxytocin is the drug which increases uterine contractility. So this oxytocin drip is given in 5% glucose solution. This glucose is doing another job to her. If she is a bit tired, if she has not eaten for a bit of longer time, this can prevent from the formation of ketone body also. So oxytocin is usually added to the 5% dextrose water and then it is given. Let's move on. Now, this is called lithotomy position. That's what I was talking a little while earlier. So please have a look there. This is an important question for you in many exams. See this. Even in surgery, this type of position is attained for certain surgery, especially on the pelvic area. So the lady is lying supine. See this, the lower limbs are acutely flexed, especially the hip and the knee joint, and they are a bit wide apart. And look at the support here. This is important in lithotomy position. The legs or the foot have to be supported. Now, this is the IV fluid. Probably they have added oxytocin here. Oxytocin on the IV fluid and then giving through the IV route. Now, what else? Okay, how we manage the second stage of the labor. See here, the main task of the obstetrician is to prevent perineal laceration. Now, let me ask this question first. What do you mean by laceration? What is laceration? Anyone?
Simply, just like incision, a huge cut.
Okay,
Sir, it
Bakir.
is a deep cut or tear on the skin or flesh, sir, to be simple.
Okay, Uzair, good answer. Anybody else? Anyone? Now, let
It
me.
is short body tears.
Okay, Zulfakar, yes. Okay, this is a type of tear. Fine. Okay, the answers are actually very near to the correct answer. Okay, there are different types of injury or the cut. If you cut that particular area with a sharp instrument, with a very sharp instrument like a scalpel or a knife, okay, remember the edges of that cut, they are quite sharp, they are not ragged, they are not irregular. This is called clean cut wound. This is not called laceration. Whereas if you cut that particular part with some instrument which is sharp but the edges are not fine, a brutal type of force is applied there, then there will be a tear or cut. But if we examine the margin are irregular. This is known as laceration. The margins are irregular. This is a type of cut, there is no doubt, but the margin should be irregular here. And it look a bit of zigzag, it doesn't look good at all, okay? This type of cut is laceration. Now what is happening here? The baby may come, suddenly outside. The lady may be vigorously pushing. There may be effect of oxytocin also. So when the baby is descending very rapidly, during that time, the perineum may be torn, okay? The perineum may be torn. So this is known as laceration. So the main task of the obstetrician is to prevent this laceration. So how they do that? They have to keep on giving support to the perineum with a sterile dressing or the towel and press it inward during uterine contraction. This is called counter force, which is applied inside. The force is applied by the uterine contractility and the baby is descending, okay? And at the same time, you have to push, okay, the perineum a bit inside so that the baby will not descend very rapidly, and this is how we prevent perineal laceration. Now see this, you have to support the perineum till crowning occurs. Now this is crowning. So how we define crowning? What is crowning now? Yes.
When the widest part of fetal head is negotiated through the narrowest part of the of the mother pelvis.
Are you sure this is crowning? You are giving the definition of engagement. What is crowning? So think again. You can answer it. Yes.
When the wide part of the fetal head uh, negotiate through the narrowest part of the maternal pelvis, and it will never recession
Okay. Now the
even after the
second.
contraction is in.
No, sir.
Yes. Yes. Good. Good. Zulfikar. Yes. Uzair. Go on. Yes.
Sir, crowning is, sir, when the baby's head becomes visible in the birth canal when it's fully dilated, the cervix, sir, mainly.
Good. Good. That is an important point. Now, let me combine these two answers together, and the complete answers would be there. The head or the presenting part is visible from outside. Okay, that means it has already crossed. Remember, it has already crossed the pelvic cavity. That's how it is visible outside. And the important point, in between the uterine contraction, it doesn't recede backward. It doesn't go inside, even if the lady is not pushing. This is known as crowning. And when crowning occurs, within a short period of time, the baby will be delivered. Now, see this? This is what the crowning is all about. The biparietal diameter, BPD, biparietal diameter of the fetal head passes through the vulval ring. Vulva, okay, is the outer part of the vagina during contraction, and the head doesn't recede in between the uterine contraction. This is called crowning. We can clearly see the presenting part from outside. So during this time, what should we do? We should constantly give support to the perineum. Otherwise, if the lady is constantly pushing, there is a severe turn or laceration of the pelvis. Now, we have a few more minutes, so let's talk about this. What are the general measures we do in second stage of the labor? We are talking in second stage of the labor now. Supervise mother and fetus just like in first stage. In the second stage of labor, perform vaginal examination, check up blood pressure, and pulse once every hour. Now, remember, in first stage of the labor, how often we do this vaginal examination? How often?
After
After
every
4
4 hours.
Very good. Every 4 hours. Once every 4 hours. Now, in second stage of the labor, we do this every hour. This is important one. And we check whether the baby or fetus is descending well, and whether the lady is having expulsive type of pushing or not. If these two things are there, we call it satisfactory progress of second stage of the labor. If these things are not there, then we are not happy with the progress in second stage. That means the baby is not descending. If the baby is not descending, then how the baby would be delivered, isn't it? Very easy to understand. And another, if the lady is not pushing, the baby cannot be delivered. Now, after preparing that lady for the delivery, or after transporting her into the delivery room, we should put her into the position. The most common position are two. One is dorsal with 15-degree lateral tilt, or lithotomy position. Now, in fact, the position should be maintained whatever the lady wants, in whichever position she feels very comfortable. That is the important point here. Okay, so in different textbook, different types of things are highlighted. These are the most two common one according to the practical experience or the practical information provided in the book. But the ultimate thing is, in which position she feels comfortable, that type of position should be attained. Once the cervix is fully dilated and the woman is in the expulsive phase of the second stage, encourage the woman to assume the position and encourage her to push. Without pushing, the delivery would be impossible. Only the uterine contraction cannot take the baby or push the baby outside. She has to voluntarily push. That means she has to contract the anterior abdominal wall muscle, okay, and use that intra-abdominal pressure as well. This is called pushing. Meanwhile, the obstetrician should follow universal precaution, that is cleaning the hand, cleaning the perineum, and using protective measures. They should wear the gown, the cap, okay, the mask, isn't it? And even the glasses, because sometimes the amniotic fluid may splash and even enter the eye. So these are all very, very important plans. Gloves will always be worn. Catheterize urinary bladder if it is full. So this is how we prepare for the delivery. Now, conduction of the delivery, okay, is discussed under 3 important headings. First is delivery of the head, second delivery of the shoulder, and third is delivery of the trunk. That's how the baby is delivered. So let's talk each of these steps. Delivery of the head, okay, starts when there is crowning. Now, so many times we have discussed this crowning. Crowning is a stage where the maximum diameter of the head stretches the vulval outlet without recession of the head even after the contraction is over. Means it doesn't go back in between the contraction. This is called crowning, and the presenting part is visible from outside. During this stage, support and clean the perineum. If you do not support the perineum, what would happen? Yes, what will happen if you do not support the perineum when there is crowning?
Laceration, sir. Blunt
Very
trauma.
good. Very good. There is a chance of laceration of the pelvis, and then later on, you have to suture it, and then sometimes the laceration may be extended towards the rectum as well. We'll talk about this perineal laceration in some other classes. These are important ones. Now, there is a concept, there is an important process which is known as episiotomy. Now, this episiotomy is the elective incision or cutting of the perineum. Elective incision or cutting of the perineum. Now, see there. It is done after crowning of the head or crowning of the presenting part occurs. It is not done in every delivery. Probably prior to 5 or 10 years before or ago, episiotomy was a regular part of the delivery. But these days, it should be considered only in chosen cases, like complicated type of vaginal delivery, where we need to apply forceps or vacuum, or a breech delivery. Okay, breech is not a normal type of delivery, isn't it? It's abnormal type because the lower parts of the fetus is presented. Scarring from female genital cutting or poorly healed 3rd or 4th degree tear, which may happen from the prior delivery, and fetal distress. The baby is having difficulty inside. Either the fetal heart rate is more than 180, or if it is less than 100 per minute, we need to quickly deliver the baby out or the fetus out, and that would be helped by giving a large cut in the perineum. This is called episiotomy. Now see this, okay? See here. After crowning, what you would do now, and what you tell that lady to do? Prevent straining after crowning. So ask the lady, do not push that vigorously or that much, okay, after crowning occurs. And if she is still straining or pushing vigorously, then suddenly the head may be delivered out, and then that is the reason for laceration of the perineum. So allow gradual and slow extension in between the contraction. Like this, constantly support the head and slowly allow the delivery to happen. Now again, this picture is showing the same thing. please focus here. Support the infant's head as it rotates for shoulder presentation. We need to keep on supporting by two of the hands. See here, very nicely shown. Guide the infant's head downward to deliver the anterior shoulder. Now, anterior shoulder is present just beyond, okay, or just posterior to the symphysis pubis. That is anterior shoulder. So you need to deliver the anterior shoulder first, and to deliver the anterior shoulder, we need to just take the head a little bit lower down, and anterior shoulder would pop out. And after that, we should extend the head again or take the head upward for the posterior shoulder to pop out. After the shoulders comes out, the rest of the body will be very easy to follow. Now, some of the important practical points regarding the delivery of the head of the baby. Ask the woman to give only small pushes with contraction as the baby's head delivers. The main reason for this is to prevent from the laceration. So only small pushes. To control birth of the head, place the fingers of one hand against the baby's head to keep it flexed. Don't allow it to extend at this time. Continue to gently support the perineum. Already talked many times. Once the baby's head delivers, ask the woman not to push now, because head is the largest diameter of the baby's body. Please remember this sentence. Head is the largest diameter of the baby's body. Once the head is delivered, rest of the body would follow easily. Okay, so the lady doesn't need to push after that. And once the head is delivered, suction the baby's mouth and nose. Why is this important? Why should we give suction to the baby's mouth and nose?
To prevent the aspiration.
For breathing.
Breathing.
Good. One is to prevent the aspiration if something is there. Very good. If something is there like meconium is there, then the suctioning of the mouth and nose is really necessary. Okay. Sometimes there is excessive mucus or excessive froth that also needs to be suctioned out. So important point is to prevent the aspiration and also to make the baby breathe easier. Okay, let's move on. Now, feel around the baby's neck for the umbilical cord. Very important step. Head has already come out, remember that, but the neck is still there or the shoulders are not yet delivered. So during that time, we should put one of our hand and then feel around the neck of the baby for the umbilical cord. If the cord is around the neck but is loose, see here, but is loose, slip it over the baby's head. That can be easily done. If the cord is tight around the neck, doubly clamp it and cut it before unwinding it from around the neck. Now, what is the meaning of this? Please listen carefully. Let me explain this for you. Umbilical cord, okay, is very commonly present around the neck. If it is loose, we don't have to worry at all. It can be easily slipped over the baby's head and no need to worry. But if it is very tight, remember the rest of the part of the baby would not come out if the umbilical cord is tight around the neck. And sometimes we cannot even slip it over the head if it is tight. So we have only one option left, and that is clamp it on two sides with two forceps and cut it in the middle. Okay, and cut it in the middle, or clamp it and then deliver the baby. Now once the head is delivered, okay, the rest of the, once you clamp the umbilical cord, remember the baby needs to be delivered quite quickly, isn't it, because the chest is still inside and the baby needs to breathe now, because once you cut the umbilical cord, the circulation from the placenta to the baby would stop. So rest of the things should follow very quickly. So this is an important point. Allow the baby's head to turn spontaneously. You don't need to do anything. These are the different mechanics of labor we have studied before. After the head turns, place a hand on each side of the baby's head and tell the woman to push gently with the next contraction to deliver the shoulder. Now this is the thing which we are talking right now. So please have a look here. Let me explain this for you. So head is delivered now. So the neck, okay, should be palpated for the presence of umbilical cord. See this. This is umbilical cord. You can see this. This is umbilical cord. Okay. If it is tightly encircling the neck, we have to manage accordingly. If it is loose, just try to slip it over the head. See this? If several loops or tight loops, apply double clamping and cut the cord in between and quickly deliver the baby out. This picture you have already seen before, if you remember. These are the different steps of the delivery of the head. See this? The head has come out. Head drops after delivery. This is restitution. This is external rotation, and this external rotation is very important for shoulder delivery to occur, because shoulders are also rotating inside. And in this phase, the anterior shoulder is beyond the symphysis pubis, and the posterior shoulder is downwards. Now, let's talk about how the delivery of shoulder and trunk occurs now. So you already know the much information regarding the shoulder delivery. So let's revise. After external rotation occurs, see this. After external rotation of the head occurs, wait until anterior shoulder is born behind the symphysis pubis. This is important point. It is present behind the symphysis pubis. During this process, you should support the head all the time. If there is a delay, head is grasped by both hands and gently drawn down until anterior shoulder is born behind the symphysis pubis. So sometimes we need to, take the head a little bit downwards, and anterior shoulder is pop out. Now another is posterior shoulder. Now draw the head upward to deliver the posterior shoulder. So this is the important practical information. After delivery of the shoulder, support the axilla. We should catch on the axilla of the baby, and the trunk is delivered gently by lateral flexion. It will easily come out because body is a smaller diameter in the baby. Once the head and shoulder are delivered, body will follow. Now the whole baby is born. So what we should do now, okay, if a pediatrician is there, we should hand over the baby to pediatrician, or if nobody is there, you give that baby to the midwife or the nurse, whoever is there, and immediate care of the newborn has to be done, which we have learned in pediatrics. For example, Apgar scoring should be done, the suctioning of the nose or the mouth should be done, baby should be kept in a warm place, which is called radiant warmer. All those wet linens and clothes have to be removed, and baby has to be clothed properly, and all these things has to be done. Now this picture also you have seen before. See this. This is how the delivery of the shoulder is done. You catch the head all the time. Okay, this is the delivery of, see this, anterior shoulder is already delivered, and this is posterior shoulder delivery, because the obstetrician is pulling the head upward to deliver the posterior shoulder, and we have to lower down the head to deliver the anterior shoulder. And this is the rest of the body of the baby. Is easily slips outwards from the vagina. Okay, so this is a real picture of the delivery process. Now, episiotomy means when the perineum is maximally stretched during the crowning and about to tear, then only you give episiotomy. We already talked about what are the indications. Remember, in all type of delivery, you don't give episiotomy these days. I will discuss episiotomy toward the end of this topic. Okay, it is also important, small lesson for you. Now, what is the concept of milking the cord? Now, what do you mean by milking the cord? Now, listen properly. Milking the cord means you squeeze the cord. You squeeze the cord and allow a bit of more blood to flow towards the baby. This is milking the cord. So, see this? Towards the fetal umbilicus, if we milk the cord, it will add around 100 ml or cc of the blood to fetal circulation. You can do some alternative way also. After the baby is delivered, you have to lower the infant or the body of the infant. You have to lower, okay, than the vaginal introitus or the vulva of the mother. Means allow some of the blood to enter into the baby's circulation with the effect of gravity before you clamp the cord. So what is the principle behind it? Let me explain again. Sometimes, okay, some babies are anemic. Some babies, we believe, they are not getting enough blood from the maternal circulation. Sometimes, the baby looks very pale at the time of birth. So this type of procedure has to be done so that some additional amount of blood is going towards the baby. But remember one thing, not all obstetricians would do this. Some things, this is an unnecessary procedure, and some may routinely do this. Now, in case of RH incompatibility, should we do milking of the cord or not? That is another question. And the answer is no. We should not milk the cord. Rather, we should immediately clamp the cord and then cut it. Now, what is the reason for this? Now, many students know what is RH incompatibility. So please let me explain this right now. So pay attention. RH incompatibility means mother is RH negative and baby is RH positive. In the first pregnancy, okay, usually nothing will happen to the baby, even if the mother is RH negative, because there is a very less chance of mixing of the mother's blood with the baby's blood. Clear? From the second pregnancy onward, because of mixing of the baby's blood at the delivery time, the mother is ready with some antibody in her system. Those antibody can easily cross the placenta and present towards the babies. Okay. Now remember, what is the effect of that antibody on the RBC? What that antibody will do to the RBC? What is the answer?
Breakdown of the RBC.
Hemolysis, breakdown of the RBC.
Hemolysis will occur.
Simply hemolysis.
Very good. Breakdown or hemolysis. Breakdown or hemolysis. Excellent. So it is already there. But if you milk the cord further, you will help more of those antibody to enter into the baby. That's why milking of the cord is not done in case of RH incompatibility. And once more antibody will enter into the baby circulation, more RBC will break down, more degree of hemolysis, more amount of bilirubin will form. This is known as hyperbilirubinemia. This is unconjugated type of bilirubin. Remember that. If the level is very high, it can cross the blood-brain barrier, it can enter into the baby's brain, and it can damage. That is known as kernicterus. Okay, kernicterus. So we need to prevent from the kernicterus to happen, and this is just one way. If it has already hemolysis, too much hemolysis has occurred, we have certain treatment for this. You don't need to worry about that. Now, some practical information, because some of you, I am sure about that, would soon enter into the delivery room, especially the girl students. Probably they are very much interested in this particular subject rather than the boys. Now, how you manage it? Even the like boy student have to know the concept, okay? Because though you don't choose this as a profession, that's different thing. But regarding the MBBS, to pass this particular degree, you have to know these things. So during the classes, when we talk about this, okay, pay attention. This is very important knowledge. How to clamp the cord and how to cut in between. So this picture is telling us that process. So let me show you now. This is okay one artery forceps which is applied here. See, it is clamping the cord on one side. This artery forceps is clamping the cord on other side, and in between you need to cut. Now, why we have to clamp on both sides? The answer is very easy. To prevent the blood loss. Towards the baby's side, you need to clamp. There is no doubt at all. Otherwise, the baby may bleed, okay, from his or her circulation. That is lethal for the baby, right? But why? Towards the placenta, also we need to clamp, just to prevent the bleeding from there also. If blood spills outwards, then there is spillage everywhere, and we need to prevent that. So on both sides, the clamping is done, and you need to cut in the middle. Now, one small point I like to highlight. Now, see there, can you see that another clamp here, the blue clamp now? I'm sure all of you can see, right? So what is the use of this now? Why we put this blue clamp here? Yes, anyone?
To prevent
To
cutting
prevent
of
bleeding,
the
sir.
intestine.
Prevent bleeding.
To prevent the bleeding, right?
Yes.
Actually, see this, let me explain. This forceps is not going to be there forever, isn't it? We need to quickly remove it. Once you remove this particular forceps, now if you have not put any clamp there, there will be severe hemorrhage. So we need to put a clamp like this and then cut in between these two clamps, and then remove. This forceps will be automatically removed after that, and within 5 to 7 days this clamp will also fall, because umbilical cord is going to shrink and it will going to dry up, and this clamp will fall by itself. You don't need to do any other thing. And this particular clamp is applied by pediatrician if they are there, or any doctor who is taking care of that newborn baby. Or if doctors are not there, then those nurses or the midwife is going to put this clamp. Now, after managing the second stage of the labor, let's enter into the management of the third stage. Now, let me ask you one question first. What is third stage of the labor? What do you mean by that?
From birth of the baby to expulsion of the placenta and membrane.
So from to the expulsion of the placenta, sir, there is a third stage.
Exactly. Everyone, I'm sure if I ask this question to all the students, they can answer properly. Absolutely correct. After the delivery of the baby till the placenta and membranes are delivered, we call that third stage of the labor. Normally, the time taken for the placenta to deliver is 10 minutes. Okay, normally it is 10 minutes, but it may take up to 30 minutes. 30 minutes is the maximum duration for third stage of the labor. If it is taking longer than 30 minutes, we call it prolonged stage of third stage, a prolonged third stage of the labor. And it has a lot of complication. The most important one is extensive hemorrhage. If not expelled within 30 minutes, we call it retained placenta, and it can lead to severe hemorrhage. Now, let's talk about how to manage third stage of the labor. This is called active management of third stage of the labor. So, what is the meaning? Active management of the third stage of the labor is active delivery of the placenta. It helps to prevent postpartum hemorrhage. Postpartum hemorrhage means after the delivery, If excessive bleeding occur, we call that postpartum hemorrhage. Partum is delivery, remember that. Post is after. So postpartum hemorrhage, very, very important term. Active management of the third stage of the labor include three things, and they are immediate use of oxytocin, controlled contraction, and uterine massage. Oxytocin will cause contraction of the uterus. That contraction helps, okay, in the separation of placenta and then pushing it downward. That's the first point. Second is control contraction. Now, if the placenta is taking time to come out, what you should do is, with one hand, you can gently give a traction on the umbilical cord. When with another hand, you have to support the uterus in the suprapubic area. Clear? So you need to give gentle traction on the umbilical cord so that the placenta is easily separated and then pulled outside. This is called controlled contraction. And uterine massage is the third step, where we have to stimulate the uterus so that it remains contractile. Uterus should contract, otherwise there will be more chance of bleeding. Now let's talk about each of these steps. Now see there, oxytocin we have to give, and every student know the use of oxytocin. Again, the answer is same. It will stimulate the uterine contractility. Now see this, within 1 minute of delivery of the baby, palpate the abdomen to rule out the presence of an additional baby and give oxytocin 10 units intramuscular. Now don't give oxytocin if there is another baby and the baby has not been delivered. If we do that, the baby would stuck inside. So this is very, very important point. So make sure there is no other baby. Sometimes it can happen, sometimes by mistake. Now how the mistake can happen? If the lady come to the delivery room in second stage of the labor, she never attend any antenatal visit. No ultrasound was ever done before, and during that time we may take lightly sometimes. Oh, there is only one baby, the abdomen doesn't look that big, and some mistake can happen. Okay, so don't take anything lightly. Just palpate the abdomen to rule out the presence of any other baby. If not, then give oxytocin 10 units intramuscular. Oxytocin is preferred because it is effective 2 to 3 minutes after the injection, has minimal side effect, and can be used in all women. Now, apart from oxytocin, we have certain other powerful type of drug which will contract the uterus. What are those? Apart from oxytocin, what are the other drugs will contract the uterus? Yes?
So you've got ergometrine, misoprostol, carbetocin, sir.
Okay. So you can, very good answer. These are prostaglandins, different types of prostaglandins, and ergometrine. So these are some of the other drugs than oxytocin. But remember, oxytocin is the most commonly used drug. And there is no point of it is not available. Okay, it is available everywhere these days, especially in those centers where birthing is happening, where the delivery is conducted. Oxytocin has to be there. If it is not there somehow, then only we go for ergometrine or prostaglandin. Do not give ergometrine to women with preeclampsia, eclampsia, or high blood pressure, because it increases the risk of convulsion and cerebrovascular accident. It will lead to increased blood pressure. That's why it is contraindicated in those situations. Let me repeat again. Make sure there is no additional baby, like there is no twin, there is no triplet or quadruplet before giving this medicine. Otherwise, there is severe danger of the delivery of those additional babies. let's move on. Now, let's talk about what is controlled cord traction. What is this procedure all about, and why should we go for this in the active management of third stage of the labor? Clamp the cord, this is umbilical cord, by 2 cord clamps. The near one is placed 5 centimeter away from the umbilicus and caught in between. We already talked about this. This is how we secure the umbilical cord. Now clamp the cord close to the perineum using sponge forceps within 1 minute of delivery. So this is an important practical point. So clamp the cord close to perineum using sponge forceps now within 1 minute of the delivery. This is a separate step from the upper one. It is easy to hold that clamp cord now, and the end of the forceps with one hand is held and another hand is kept in the suprapubic area of that lady to stabilize the uterus. Remember, with one hand you are giving traction, or you are pulling the umbilical cord outside. If we do not support the uterus during that time, the whole uterus may be pulled outside, and this is known as inversion of the uterus. Now, inversion actually means the uterine cavity, the inner part of the uterus, the cavity of the uterus is called uterine cavity, and the inner layer is the endometrium. We all know that. So it will be inverted. The endometrium would come out. Okay. So endometrium would be the outer layer, and the perimetrium would be the inner layer in case of inversion of the uterus. So the inner layer would come outwards, and the outer layer would become inwards in case of inversion. This is a very, very serious complication. That's why, to avoid this complication to happen, I need to put one of the hand in the suprapubic area and apply counter traction when I'm doing control contraction. So this is done by the obstetrician or the midwife or the nurse who is delivering, okay, that particular baby or the placenta. Keep slight tension on the cord and wait a strong uterine contraction that can happen after 2 to 3 minutes. This is known as controlled contraction. Now let's see some of the picture here. See this? This picture is highly informative and you can easily understand this. This is the sponge forceps which is applied quite close to the perineum. Now this is the umbilical cord. Okay, those two clamps which we have already kept are not shown here. Okay, they are already removed. Now this clamp will take care of everything because the baby is already delivered. That end is already cut, so only placenta is left inside. You see this. Now what should we do? With one hand you have to pull. You have to pull this umbilical cord, and look here, where is the other hand? It is giving pressure on the suprapubic area. So it is pushing the uterus upward so that uterus will not be inverted when we pull the umbilical cord. So this is the one. These are the signs of placental separation. Progressive lengthening of the cord because placenta is descending downward, and there is a gush of the blood. After the separation of the placenta, some bleeding will happen. So these are the two signs of placental separation, and you are quite happy that the active management of the third stage of the labor is progressing well. See here, this is another picture which is showing the same thing. The placenta is almost about to deliver now. It is in the introitus, and you are constantly pulling the umbilical cord, okay, with the sponge forceps there, so that you can give a good traction force. And with other hand, this is very, very important, other hand is constantly pushing the uterus upward. This is known as counter traction. And this is a real picture. Here the placenta is being delivered outside, and still look at that hand. It is constantly pushing the uterus. This is known as guarding the uterus, or giving counter traction, or giving pushing force to the uterus, so that only the placenta comes out, not the uterus, or it is not inverted. Let's talk something more about control contraction here. When the uterus becomes rounded, that means well contracted uterus, or the cord progressively lengthen in length, very gently pull the cord downward to deliver the placenta. You all know this point, isn't it? We are talking about this process now. Do not wait for a gush of blood before applying traction on the cord. When the gush of blood comes, you already know placenta is separated. Continue to apply counter traction to the uterus with the other hand, otherwise there is a high chance of inversion of the uterus. So this is a very important step. And one more important practical information here is, if the placenta doesn't descend during 30 to 40 seconds of controlled contraction, or in other words, there are no signs of placental separation, do not continue to pull on the cord blindly. Do not only pull on the cord. See this. Now, you need to be careful here. You need to gently hold the cord and wait for the good uterine contraction. And when the uterus is contracted again, you repeat the same process. That means wait for the help from the uterine side. You do not simply pull the cord consistently. If you do that, there is a danger of uterine inversion. And give counter traction all the time, or push the uterus at the suprapubic side all the time when you give a good amount of pulling. And that is done by the use of sponge forceps, which you have used to clamp the cord closer to the perineum. So this is a very important practical point. All of you, this is the delivery of the placenta. The placenta will gradually lengthen, okay, and there is a fresh gush of blood coming out. We know placenta is separated, and then we can also see the placenta at the vulval outlet. This is a schematic diagram though, but it is very informative. Let's move further. As the placenta delivers, the thin membrane can tear off. Now, which membrane we are talking about? Which are these membrane? Yes? What are the names of this membrane? These are amnion and chorion. Okay, amnion and chorion. Now, especially the amnion. So it can tear off on its own. Hold the placenta in two hands and gently turn it until the membranes are twisted. That means the membranes are separated from the uterine cavity and they are delivered outside. Slowly pull to complete the delivery. Means pull the placenta. If the membranes tear, gently examine the upper vagina and cervix wearing high-level disinfected or sterile gloves, and at the same time use a sponge forceps to remove any pieces of the membrane that are left behind. So what does that mean? Sometimes some of the membrane may left behind in the cervix or in the upper part of the vagina or even inside the uterine cavity. We need to take them out completely, otherwise there is a chance of prolonged hemorrhage. So this is a part of active management of third stage of the labor. Now see this? This is a schematic diagram, but very informative. Look at this membrane which are covering the placenta. Okay, these are the membrane. So along with the membrane, the whole placenta is delivered. So you need to support the placenta with both of their hands, slowly twist it when it is being delivered, and all the membranes would come out as one unit. If the membranes are turned, you need to explore if membranes are left behind inside or not. So these are the different picture, again explaining the same mechanism. See this, the first one, the traction force is applied on the sponge forceps, and with other hand the counter traction is given on the suprapubic area. The second one, now see this, uterus is already, placenta is already separated, and you can see placenta is coming out, and there is progressive lengthening of the cord. Now when the placenta comes out, support the placenta with both hands, slowly rotate it so that all the membranes would come out as one unit, and this is the delivery of the placenta with membrane. Okay, so this is the way. See this, look at the delivery of the membrane now. Okay, these are the leftover membrane which are delivered, and if something is left behind, you need to explore and deliver them again. Now let's move further. Look carefully at the placenta to be sure none of it is missing. This is a very important examination we like to do after placenta is delivered. If you remember long time ago, when we talk about the placenta class, during that time I clearly told you this is a regular part of the process. We must examine the placenta. Now one small question I like to ask here. Why you examine placenta all the time? Why? Yes, who can answer this?
Sir, if there is any portion is
Sir,
missing,
look
it
for any
means that there
placental
is
abnormality, like placenta,
any.
sir, any type of placental abnormalities are looking for that.
Okay, good. Irfan, very good answer. And Uzair also, they are saying the same thing actually. Very good. One is to check whether there is any anomaly of the placenta or not. Okay. Sometimes placenta is missing one big lobe or one big piece. Sometimes one piece is farther away from the main placenta, okay, which is known as placenta succenturiata. Sometimes the umbilical cord is attached at the membrane, and then those blood vessels are going a little bit farther away, and then they are mixing on the main substance of the placenta. This is known as velamentous insertion of the umbilical cord. We need to examine the umbilical cord as well. How many blood vessels are there? How many arteries? How many veins? Okay, and sometimes there is only one umbilical artery present. This is known as single umbilical artery. So to rule out all these things, you need to carefully examine the placenta along with umbilical cord. This is a very, very important point. If a piece is missing, okay, we need to re-explore again. If uterine inversion occur, reposition the uterus. It should not occur. Remember that if it occurs, then the management which you are doing in the active management of third stage of labor is faulty one. Nobody should invert the uterus during delivery of the placenta. But somehow, if it occurs, you need to reposition the uterus. You need to push the uterus back. If the cord is pulled off, manual removal of the placenta may be necessary. Okay, if the cord is torn, for example, if the umbilical cord, then we need to insert our hand inside and take the placenta outside. This is called manual removal. Now that's what I was talking right now. So see this, okay. Can you give the diagnosis of this particular placenta? What it is called?
Succenturiate lobe.
Low formations are on the placenta.
Exactly. This is the additional lobe. So placenta succenturiata or succenturiate lobe of the placenta. See this? Now this can be easily missed if you do not examine properly. The blood vessel is going to this part. Okay, this is the main umbilical cord, and this is the main substance of the placenta. So this is how we need to examine it properly. Now, what is the concept of uterine massage? Let's talk about it. This is the third important part of the active management of third stage of the labor. So what are we doing? Immediately massage the fundus of the uterus through the woman's abdomen until the uterus is very hard or contracted. The uterus which is well contracted is having hard type of feeling. Okay. Repeat this uterine massage every 15 minutes for the first 2 hours after the delivery. Especially we have to do for the first 1 hour. It really helps to decrease the bleeding from the uterus. And sometimes the uterus, will not contract. This is called uterine inertia or uterine atonia. Now that is a very important risk factor for postpartum hemorrhage. Constantly massaging the uterus will stimulate the contraction, and the postpartum hemorrhage, the chances will be very less. Now, another important examination at that time is examination for tears. Now, those tears which I talked a little while earlier, these are called perineal tears or perineal laceration. So, examine nicely about those laceration or the tear in the perineum. If there are any, go for the repair. Okay. If you have given episiotomy, episiotomy is the elective type of cut. So we widen the birth canal by cutting the perineum. This is called episiotomy. If you have given it, go for the repair as well. Check the cervix, check the vagina, check the perineum, check the vulva, and whatever tear is there, you need to repair it. If there are major tears, definitely need to repair. Some minor tear can be healed by itself as well. Now, at the end, let's talk about what is episiotomy, what are the different indications, okay, and in which situation we need to give it. Those are called indications, isn't it? And the related things. Now, see here. Every student know what is episiotomy. So let's talk about the indication. Indication means in which situation you give it. Episiotomy should not be performed routinely. It is a cut. It is an injury you are inflicting there. So if it is not necessary, why you go for it, isn't it? This is the important point. These are the important indications. Number one, complicated vaginal delivery like breech delivery, shoulder dystocia, forceps delivery, and vacuum extraction. So these are complicated vaginal delivery. During that time, we need a wider type of birth canal. So episiotomy is indicated. Now, breech delivery means, what is breech delivery? Let me ask once again. Breech delivery means what? Who can answer this? Say it again.
Sir, the lower limb presentation.
Okay, Ehsan, good. You can say the lower part of the body is presented first. Absolutely. Breech has a buttock presentation as well as lower limb presentation, especially the buttock one. Okay, that is breech. It is always considered abnormal type of presentation. Shoulder dystocia. Now remember, eutosia is a normal labor. Dystocia means abnormal one. That means shoulder are not delivered easily. Shoulders are not coming out. So we need a wider birth canal for the delivery of the shoulder. So episiotomy is indicated. Forceps and vacuum are called instrumental delivery. We need to insert the forceps from the side, okay, and vacuum. Vacuum is applicable once the baby is not coming out. Vacuum delivery is done to pull the baby out. So all these are important indications for episiotomy. Second one, scarring from female genital cutting or poorly healed third or fourth degree tear from the prior delivery. And if fetal distress is present. Now, what is the meaning of fetal distress once again? What is the meaning? Who can answer this?
If the fetal heart rate
Difficulty inside fetus.
more than 180.
Any difficulty.
Good, good. Or less than
Less than 100.
100. I agree with both of these answers. The meaning, the literal meaning of fetal distress is if fetus is having some difficulty inside. In other words, if the fetus is having hypoxia inside, this is fetal distress, and we diagnose this by measuring the fetal heart rate or counting the fetal heart rate. If it is more than 180 per minute or less than 100 per minute, or one more thing is if the amniotic membrane is already ruptured, and if that amniotic fluid is having meconium, it is also another point for fetal distress. Let's move on. Now see that. What is the procedure? As a medical student, when you go to the obstetrics internship, your senior would definitely ask you to suture that episiotomy wound. So, but before suturing, you should know how to do it, how we do it, isn't it? If you will get the chance to give episiotomy, how you give it. So let's talk about this, the procedure. Review general care principle and apply antiseptic solution to the perineal area. So all those general care principle means the universal precaution has to be followed, and apply povidone iodine to the perineal area at least for 2 minutes. 2 minutes time is necessary for that iodine to act. Then provide emotional support and encouragement to that lady. This is a painful procedure. You are cutting that area, but during that time, the pain from the natural labor process is so much that that lady probably would not feel more pain. Now think about it. How severe is the labor pain? You are cutting tissues there, and that pain would not be felt by the lady because she is having another much more severe pain than that. But still, you have to explain the situation. Okay. Use local infiltration with lignocaine. What is lignocaine?
Local
Local
anesthetic
anesthetic.
drug.
Sir, it is a
Exactly.
local anesthetic used to numb the tissue at some time, sir.
Exactly. This is lignocaine, also known as lidocaine. Okay, lidocaine or lignocaine, it's the same term. This is a very commonly used local anesthetic drug. It is used to infiltrate in that area where you are doing some surgery. You are cutting that area, so there will be no pain. Make sure there are no non-allergy to lidocaine or lignocaine or related drugs. Infiltrate beneath the mucous, vaginal mucosa, beneath the skin of the perineum, and deeply into the perineal muscle using about 10 ml of 0.5% lidocaine solution. So this is the way we infiltrate that area with local anesthetic drug. And after we give that, okay, wait for a minute or so, and then you cut it. Okay, this is the way. Otherwise, there will be severe pain. Though I already told you the pain which is felt by this cut may not be that in this particular situation, but we still want to do this procedure. One small question for you. Before you push lidocaine inside any tissue, there is one practical thing you like to do. Probably I have explained this before also. What is that? What you want to do there? You want to aspirate it back.
Antiseptic.
Okay, you want to aspirate it. Now you have already cleaned it with antiseptic. You have already done this. Okay, but what I'm asking is before you give that injection inside, because you don't know where that injection is going, isn't it? You may hit the blood vessels there. Blood vessels are everywhere, and if the tip of the needle is inside the blood vessel, and if you push the lidocaine directly into the blood vessel, it will be a disaster. The lady will have seizure because of the lidocaine effect. I don't want to do that. So to avoid hitting the blood vessel, just aspirate a little bit back and check whether the blood is coming into your needle or not. If the blood is not coming, you are safe. You are not into the blood vessel, then push the lidocaine into the new tissue. Always remember this. Wherever you are giving lidocaine, this is the way. Now look at this picture. Okay, this is a very informative one. This is the way you give lidocaine into the tissue, and look at the direction of this needle. You are exactly going to cut like this. Okay, this is a lateral type of incision. Mediolateral. This is the midline, and this is the lateral side. Now see this? This is how we are cutting it. Prevent the accidental cut on the baby's head or baby's organ. Okay, put 2 of your finger there and protect the baby from the scalpel or from the scissor. Rather than scalpel, we use episiotomy scissor here. Now this is a schematic diagram, but very informative one. You have to cut like this. See this? This is episiotomy scalpel or scissor, I should say. Sorry, episiotomy scissor. Cut it like this. This is mediolateral cut. This is the midline, and this is the lateral mediolateral cut. And these are the different perineal muscles. So these muscles are also cut during that time. Now, wait to perform episiotomy until the perineum is thinned out and 3 to 4 centimeters of the baby's head is visible during a contraction. This is known as crowning. We already talked about. Crowning is this. So after the crowning occurs, then you can do the episiotomy, because within a short period of time the baby would be delivered. Wearing high level disinfected or sterile gloves, okay, is necessary. Place 2 of your finger between the baby's head and the perineum. And why we do that? To prevent the accidental cut or injury to the baby's head. So this is important one. With the help of episiotomy scissor, you cut the perineum about 3 to 4 centimeters in the mediolateral direction. This is important point to remember, because these are the important MCQ question which will be asked in the exam. See this, mediolateral position or direction. Use scissor to cut 2 to 3 centimeters up the middle of the posterior vagina as well. Control the baby's head and shoulders as they deliver, ensuring that the shoulders have rotated to the midline to prevent an extension of the episiotomy. So this was already discussed in the mechanics of the labor. We need to support the head all the time. Remember, we have to deliver the shoulder one by one. First anterior shoulder, then posterior shoulder, and then catch the baby into the near the shoulder. Okay, that is called axilla, isn't it? The axilla on both sides. We have to catch the baby with both of your hand and slowly laterally rotate the trunk so that the whole baby will be delivered. It should be done one step after the other. Carefully examine for extensions and other tears and repair at the end. This repair is the job of the junior most doctor there, and you should take this as the chance which is provided to you by your seniors. Do not run away from this responsibility. Okay, this is the thing which you have learned in surgery and also in obstetrics. Suturing is not that difficult thing at all. Suturing, now that would be taught to you during practical, but right now we cannot teach you that. So when we return to the university, I'll definitely conduct some of the practicals, and during that time all this suturing and these catheterizations and these important things will be taught that time. Now see this, this is the the last slide regarding episiotomy. This is how we need to repair the episiotomy wound this is suturing of the episiotomy wound. Look at the directions of this episiotomy wound. You can clearly see mediolateral from the midline, okay, it is known as posterior foreset actually. We are cutting it laterally, and a good type of repair has to be done. Now, one small question before I end today's class. What we suggest her, how she take care of this episiotomy wound? What should be done? Yes, I want to listen some answer. What needs to be done later on? Because we are going to discharge her very soon, probably after 1 to 2 days. So how she can take care of this episiotomy wound? Anybody?
Prevent from straining, and mostly spine position is better.
So the first point is like, sir, it takes almost 7 to 10.
Okay, good, Irfan. Yes, Uzair, I'm listening.
Sir, antibiotic, propylate antibiotic use.
Good, Abbas, good. Yes, Uzair, you are saying something. Continue. Anybody else? Now, this question may be a bit difficult for you, so please pay attention. Let me explain this. This is a cut. This is a wound. Just like any other wound in our body, we suggest the same thing. Take care of that area, isn't it? Like proper dressing has to be done. Do not strain unnecessarily. While they go to toilet and these type of things, do not soil that area. These are important points. And sometimes what happen, there is infection occur. Now can you tell me how that lady identify the infection has occurred in the episiotomy wound? What are the signs? One is swelling, another pain.
Any pain.
Exactly.
And
Exactly.
any pus.
Any pus, very good. So these are the things. If that area is unnecessarily red, if that area is more painful than before, if there is discharge of the pus, if there is excessive discharge, that shows this episiotomy wound is infected. And now this is a very important complication. That lady must go to the hospital again, and that suture has to be removed. Then only the wound can be taken care of. Any infected wound, if sutures is applied there, we need to remove that suture. Okay, keep that wound open, treat that infection, and then resuture the wound again. If it is a major type of infection, if it is a minor type of infection, sometimes it happens, only one end of the episiotomy wound is infected, then just wait for it. Give antibiotic, some local application, okay, it would get better after few days. And many of the time you don't need to even take the suture out. These are absorbable suture which are applied these days. So this is all about the episiotomy. At the end, let me repeat a bit of important points again. Episiotomy is the cutting of perineum in mediolateral direction. It is not given to all the ladies. It has to fulfill some indication. These days, some of the obstetricians even say the natural laceration, okay, which occur during labor is better than episiotomy if these lacerations are not extensive. Okay, they even say that. What does that mean? The routine practice of episiotomy is not done. It has to have some indication. Some abnormal type of labor like breech delivery, shoulder dystocia, when you apply some instrument, those are the important type indications for episiotomy. And after you give it, you need to suture the wound quite well and ask the lady to take care of the episiotomy wound at home. And if there are any signs of infection, return to the hospital quite early so that it can be handled in time. So let me end today's class here.